Hello, guys. Welcome to AMC Prep Talks. Today the topic of our video is long-term management of acute coronary syndrome. In the previous videos, I've covered the STEMI and non-ST elevation MI and their acute managements. Now we are going to do the long-term management of acute coronary syndrome. So starting with that, first we have the antithrombotic therapy. And in antithrombotic therapy, we have dual antiplatelet therapy and and there's another thing that is called as triple antithrombotic therapy. So in antithrombotic therapy, we have antiplatelet therapy in which we give aspirin plus P2Y12 inhibitors, which can be prasugrel or ticagrelor. These are the preferred ones. So this is the antiplatelet therapy recommended for all the patients who have undergone the acute coronary syndrome, and this is called as the dual antiplatelet therapy. So dual antiplatelet therapy is for 12 months with aspirin continued. So the dual antiplatelet therapy is recommended for 12 months, and the P2Y12 inhibitors can be stopped after 12 months, with aspirin is continued lifelong. And when there is a risk of bleeding, so dual antiplatelet therapy can be considered in less than 12 months. And more than 12 months of dual antiplatelet therapy is considered when there is risk of recurrent acute coronary syndrome. So it can be given for more than 12 months, but the classical duration for the dual antiplatelet therapy is 12 months. And when the aspirin is in contraindicated, P2Y12 inhibitor alone can be used. Then we have the triple antithrombotic therapy. So when is the triple antithrombotic therapy indicated? It means it has antiplatelets plus anticoagulant therapy. So in patients who have undergone PCN and have an indication for oral anticoagulants, they are indicated to have the triple antithrombotic therapy. Oral anticoagulants are given in the patients with atrial fibrillation. So if the patient has the history of atrial fibrillation and he is on the therapy of oral anticoagulants and he has undergone PCI and acute coronary syndrome, he has to be given the dual antiplatelet therapy, and along with that, he is given anticoagulant therapy. So it is termed as the triple antithrombotic therapy. So for the first 1 to 4 weeks, triple antithrombotic therapy is recommended for 1 to 4 weeks. Then it is followed by dual therapy, and in this case, dual therapy is the oral antiplatelet and oral anticoagulant. So oral anticoagulant cannot be stopped because the patient has atrial fibrillation. So it is to be given, and along with that, another antiplatelet drug can be added. So in the first 1 to 4 weeks, triple antithrombotic therapy is recommended, and which is then followed by dual therapy, which contains oral anticoagulant and oral antiplatelet. And here, the preferable antiplatelet is the clopidogrel. Now, after 12 months, oral anticoagulant may be used only, and the antiplatelet therapy is discontinued. If the patient has moderate to high risk of stent thrombosis, so oral anticoagulant can be given with P2Y12 inhibitor. For the patients who are on antithrombotic therapy and antithrombotic therapy like antiplatelet and dual antiplatelet and triple antithrombotic therapy, they are given proton pump inhibitors to reduce the risk of GI bleeding because they can cause GI irritation and ulcers. So they increase the risk of GI bleeding. So with these treatment, PPIs are given. And in the case of triple antithrombotic therapy, pantoprazole is indicated because omeprazole and esomeprazole are contraindicated with clopidogrel. And in the case of triple antithrombotic therapy, the antiplatelet is antiplatelet, which is clopidogrel, is indicated, and omeprazole and esomeprazole are contraindicated with clopidogrel. Hence, pantoprazole is the PPI, which is used in the triple antithrombotic therapy. Then we have the statin therapy. Statin therapy is also given in all the patients with acute coronary syndrome, and it reduces the premature death and myocardial infarction. ACE inhibitors and ARBs, and if ACE inhibitor is intolerable, ARBs can be given. For example, if the patient has develop the side effect of severe cough. So ACE inhibitors can be discontinued, and ARBs can be given alternatively. Can be given, and ACE inhibitors reduce cardiovascular mortality after MI, and it also benefits in the patients with a heart failure with reduced ejection fraction, and diabetes mellitus, hypertension, and chronic kidney disease. Early usage is indicated after the acute MI. It is contraindicated earlier when hemodynamic instability is there and systolic BP is less than 90. So most of the long-term treatment of acute coronary syndrome is given after the patient gets stabilized, and after the patient has undergone the PCI. Then we have beta blockers. Beta blockers are given for 12 months of duration, and they are given when there is successful revascularization, no angina, no ventricular dysfunction. So beta blockers are also only given when the patient becomes hemodynamically stable, and if it is indicated for more than 12 months if the patient has ongoing ischemia or left ventricular failure symptoms, and if there is ventricular dysfunction. So heart failure specific beta blockers are given, which are carvedilol, bisoprolol, metoprolol, succinate. So we have to start the beta blocker once hemodynamically stable. I've already said it. And suitable regimens to start with would be atenolol and metoprolol. And beta blockers can be stopped earlier if there are adverse effects. So the treatment, a long-term treatment that is given for 12 months only, is dual antiplatelet therapy and beta blockers. Other treatments are given for lifelong, that is statin therapy and ACE inhibitors. So this is the long-term treatment for acute coronary syndrome from eTG guidelines, and I have covered all this. Thank you for watching.